All right. So, well, welcome everyone. Thank you for being here. I'm Lindsay. I'm the program coordinator at the Longmeadow Adult Center. For now, if you could please mute yourself. We are so lucky to have Dr. Holman with us today, and she's a cardiologist at Pioneer Valley Cardiology, and she's also a Longmeadow resident, so she's excited to share.
That sounds like my house.
I have my little, my health. Whoop, the timing isn't perfect, but so I will let Dr. Holman take it away from here.
Hi guys, hello everyone. Nice to meet you all, nice to see you all. My name is Dr. Sujata Holman. As Lindsay said, I worked at Pioneer Valley Cardiology. We're located, we have a couple locations. We are at 300 Stafford Street in Springfield, attached to Mercy, and we're attached to Bay State as well. So thank you all. First of all, thank you, Lindsay, for inviting me. This is really great to kind of see everyone in their normal environments. Yeah, and thanks to all of you for listening in. So I'm going to go ahead and get started here. So we're going to share. So this is like my first time doing a PowerPoint on Zoom. So just, you know, there might be some technical difficulties, so we'll just get through it. So my talk today is going to be about heart health in general, and it's titled Have a Healthy Heart, Heart Disease as We Mature. And I'm really going to focus on heart disease as we get older, specifically over 65, and some of the normal changes that happen, and then some of the pathologic changes that can happen. Just to go over a basic overview, I'm really going to focus on the basics, because I think that's really important to understanding heart disease, is understanding the fundamentals. So we're going to go over, I split it into three different groups. The inner plumbing, or the inside of the heart, that's the chambers of the heart, the valves, arteries. And then we're going to talk about the outer plumbing, which is the heart arteries or the coronary arteries. And then we're going to talk about the electricity. So I like to keep those three things separate, because I think that's important in kind of pinning down heart disease with a little bit more accuracy. We're going to talk then about some of the changes that happen with normal aging. So this is not independent of disease. This is what happens as we get older. We're going to talk then about some of the most common conditions that I treat and see as in a cardiology practice in my folks that are older than 65. And then we're going to talk about what a cardiologist is in detail, like what is our training and when you would potentially need a cardiologist in addition to your general practitioner. And then lastly, as is kind of a tit for tat, as a reward for me doing the talk, they're gonna blessedly let me promote or plug my the nonprofit that I'm involved in. So it's Have a Healthy Heart, literally and figuratively, and it's called the Borgen Project. So we're gonna talk about that at the very end, and then I'll be able to answer any questions. So let's go ahead and get started. So I'm biased, but I think the heart is a pretty awesome organ. I don't know about the rest of you, but I find it amazing. The average human heart is only about the size, so probably two of my fists or one of a very large fist, and it never gets a break. You know, after about an hour or two of work, I want to go and stretch and take a break. Well, your heart doesn't get that chance. It has to work 24/7, 365 days a year. And it never gets a break from the day you're born until the day you die. And it pumps about 2,000 gallons of blood a day and up to 100,000 times a day and 35 million times a year. So it's a pretty amazing organ. It also feeds itself. So it gives itself nutrients and oxygen. It has its own internal plumbing and electricity, and it's able to adapt quickly to any kind of, you know, environmental stimulus. So it's in constant feedback with the brain and the nervous system. So it's able to respond to anything. So it's pretty awesome. So when we talk about the internal plumbing, I want to go through it kind of in detail. I like to think of the heart as kind of like a garden hose. So it's a series of things in sequence. And if you think of it unraveled as a tube, I think that's helpful. So first we start with the body, and we start with deoxygenated or oxygen poor blood that comes from the body and tissues and organs. And that travels via the veins into the right side of the heart via two major veins. So there's the SVC or superior vena cava and the IVC or inferior vena cava. IVC drains blood from the bottom half of the heart, and the SVC drains blood from the top half of the heart. And they meet in the middle to the right atrium, which is the top right chamber. So there's the top right chamber, so all the oxygen poor blood goes into the right atrium. That funnels from the right atrium through the tricuspid valve into the right ventricle, or the bottom right chamber. That goes out to via the pulmonic valve to the pulmonary arteries, which is that big artery that takes the oxygen poor blood to the lungs. And then you breathe out your carbon dioxide and you breathe in your oxygen from the air, and that goes into your lungs. It oxygenates your blood. And then it goes via the pulmonary veins to the left top chamber and the left bottom chamber. Can you guys see that? I can't really see it, but
yep, we can see your screen.
Perfect. So the left top chamber or the left atrium, and then that goes into the left ventricle. So this is the circuit, and it's really important to remember that. And I always have to go back to it, just the fundamentals. So let's talk about the valves. The valves, there's 4 of them. So there's a tricuspid valve, which sits between your top right chamber, or right atrium, and your right ventricle. Then there's your pulmonic valve, which goes from your your right ventricle to your pulmonary artery. Then there's your mitral valve, which sits between your left top chamber and your left bottom chamber, left atrium and your left ventricle. And then there's your aortic valve, which sits between the left ventricle and the aorta, which is that large artery that carries blood, oxygen-rich blood to your cells and tissues. And this one is particularly important as we get into disease states of the heart, because we see a lot of abnormal aortic valves as we get older. And so when we talk about heart imaging, we always want to separate what we're looking for. So when we want to look at the heart as a whole, like the internal structures, the ventricles, the atria, and the valves, we're going to do a test called an echocardiogram. So some of you may have had an echocardiogram before. That's looking at these structures to making sure that they're moving right, that they're opening and closing right. And so that's what we'll be able to tell from an echocardiogram. So from the inner plumbing, we're going to go to the outer plumbing. And when I say outer plumbing, I literally mean outer. So this is kind of a blown up diagram of the heart. And so what I'm talking about are the heart arteries. So the heart pumps body to the aorta, and then the aorta, actually the first branches off the aorta are the coronary arteries. So the heart pumps blood to itself. And that's important to remember, because the heart muscle is one of the organs that requires the highest amount of oxygen. So it's really important that it's able to pump oxygen to itself. And so the coronary arteries are really tiny, and they run on the outside surface of the heart. And, a lot of times people ask, how is my echocardiogram? Could you see any blockages? And I can't. The echo is not a good enough test to look at the tiny little coronary arteries. The only way to really look at these is with an angiogram or a catheterization. So we actually snake a catheter up the artery, usually either the artery in the leg called the femoral artery, or the radial artery, which is in the hand or in the wrist. And we snake an artery up to the coronaries. We engage the coronaries. We put it right at the opening, and we inject dye, and we actually directly look at these arteries, and we're able to see blockages that way. So the way to really look at the coronary arteries is with an angiogram or a catheterization. That's kind of the outer plumbing. Now let's talk about the electrical system, because that's a completely separate entity, and it's sort of important to keep these things separate, because an abnormality in one doesn't necessarily mean you have an abnormality in the other. So the electrical system is made up of specialized muscle cells, and they're in little groups called nodes, or in tracts, which are just long fibers. And they're able to propagate an impulse or an electrical circuit, so that's the signal that tells the heart when to beat and how fast to beat. So it starts in the sinus node, which is sits in the top right atrium or top chamber. And it's called the sinoatrial node, actually, or SA node. And when you've heard the term, I don't know if some of you have heard the term normal sinus rhythm, that is because it generates in the sinus node. So it's a normal sinus rhythm. This is the primary pacemaker of the heart. And it runs between 60 and 100 beats a minute, and that's the normal heart rate. So a normal heart rate would be 60 to 100 beats a minute from the sinus node. And then the electricity goes to the left atrium and the rest of the right atrium. And then the atria contract. So when we think about what the heart sounds are, we usually say lub dub, lub dub. So when the atria contract, that's like the lub of the lub dub. And then the electricity gets funneled into the AV node, or the atrioventricular node. It sits between the atria, or the top chambers, and the ventricles. Okay, pretty self-explanatory there. It's actually in the bottom of the right atrium. And then the electricity goes down to the right bundle branch and the left bundle branch. So you guys, I don't know if some of you have heard of the term bundle branch block. That's a delay in conduction going down one of the bundle branches. And so this is a very vital and important part of the heart's function as well. And the way to really get a good snapshot, simple, easy test is an EKG, or an electrocardiogram. Some people also call it an ECG. This is just a generic example of an EKG, and it gives us a 6-second snapshot of what's going on with your electrical system of the heart. So now we're going to transition from kind of the basics to getting into the physiologic changes that occur as we get older. I'm going to highlight this and separate this from what happens in abnormal hearts. This is what happens even in normal hearts, in people who are aging normally. And so with the arteries themselves, the arteries get stiffer. And that's usually manifested if you get your blood pressure checked. Your blood pressure will rise because your arteries are stiffer. The top number will rise. The bottom number usually stays about the same, or maybe goes down a little. So when you subtract the bottom number from the top number, you get what's called the pulse pressure. So as we get older, our pulse pressure gets a little bit larger. And I'm going to show you a little diagram here. This is a younger artery, and this is an older artery. There's 3 layers to the artery wall. There's the inner layer, or the intima. There's the middle layer of media. That's the muscle layer. And then there's the outer layer, of the adventitia. In the older heart, your muscle layer your muscle cells will get larger. And you'll also get a lot more scarring on the inner layers. So it just gets a little less compliant. And so you will see that as a rise in the top number of the blood pressure. You also get some conduction disease sometimes. You lose cells in those electrical nodes, so the SA node, and you'll also get some scarring of the conduction system. And so that will lead to a resting heart rate that's a little bit lower as we get older, but also a decreased response to stress states like infection. So you'll get less of a rise in the heart rate, and you'll get less of a rise in the heart rate in response to exercise. And so overall, that can lead to kind of a gradual decline in functional capacity and your ability to exercise. But you can actually attenuate that. You can lessen that decrease by exercising regularly and trying to stay physically fit. The other thing that happens is the left ventricle, or the heart muscle itself, gets a little bit larger, so it can be more thickened on an ultrasound. And that's because the individual muscle cells are actually responding to an overall loss of muscle cells, so each individual cell gets larger. And then you can also get fibrosis or scarring with calcium deposits on the valves. So this can be just a process of normal aging. But there is good news. I don't want everyone to take away that this is all doom and gloom and all this stuff is happening. We are living a lot longer. We are dying less from heart disease and stroke. There's been a 35% decrease over the past several years. So we're doing better at targeting the risk factors that cause diseases, and we're living longer. We're also living better. We're more functionally able, even into our 8th and 9th decades of life, as many of you can attest to. We also have a lot more options for treating heart disease. So, that's why we say, don't ignore it, because we actually can do stuff nowadays that's minimally invasive, and that's relatively simple and low risk. And then a lot of these disease states are largely preventable. So we're going to talk a bit about some of the risk factors, which I'm sure many of you have heard from your general practitioners and just community messaging. We can prevent or reverse a lot of these disease states, which is great. So there is good news. So we're going to shift and talk about some of the common conditions that I see in my clinic. I'm, like I said, I'm a general cardiologist. I'm going to focus on the conditions that I see in my population 65 and older. So number one, first and foremost, we see a lot of coronary artery disease or heart disease or atherosclerosis. And what that is it's a long-term process. You know, I talk about this in aging, but this process really develops in your 20s and 30s. And how fast it develops really depends on your underlying genetics and the risk factors and your diet and your lifestyle. So basically what it is the buildup of these lipid-rich, these cholesterol-rich and fat-rich plaques in the arteries, not just of the heart arteries, but in all the artery beds, but because I'm a cardiologist, we're talking about the heart arteries. Over time, that can cause narrowing in the heart artery lumen or the opening. And so that results in a decrease of blood flow, like ultimately a decrease in oxygen and nutrients getting to where it needs to go. So that presents in two different ways. It presents as stable angina or angina, which is a gradual and slow buildup of plaque in the arteries. And usually these stable angina plaques have calcium over them, so they're not the plaques that cause heart attacks. And that's really important to distinguish. And why we call it stable is because it's predictable. It happens with a certain amount of exercise and it goes away with rest. And so it's very predictable. You can set your time by it sometimes. And we really need to distinguish that from unstable angina or angina, which is otherwise known as a myocardial infarction or MI, which is otherwise known as a heart attack. And there's a couple other terms I mentioned. And that is really when you've got a small plaque, not a very, large plaque like this one, and it somehow gets exposed to the artery opening. And when something gets exposed where it's not supposed to be, the immune system says, uh-oh, and it starts to attack. So that causes a lot of inflammation in the local environment, and that can cause clot. And when a sudden clot forms, it can suddenly cut a lot of the blood supply to the heart muscle, or it could completely cut it, and that's what you feel as a heart attack, where you get a sudden onset of chest pain or pressure or shortness of breath or whatever your symptom is. And that really is a medical emergency. That's something that's, requires a 911 phone call and, get in immediately. So that's really should be distinguished from stable angina, which is more predictable. Another disease state that I often see is congestive heart failure. Now, many people live with congestive heart failure, and what it is it's a clinical syndrome. So you cannot diagnose congestive heart failure by a test, by an echo. It must be diagnosed by talking to a patient and listening to them and looking at their physical exam. So it's a clinical syndrome of any number of symptoms that describes the heart's inability to meet the metabolic needs of the body. So the most common symptoms that I see are shortness of breath with exertion, swelling in the legs or bloating or swelling in the abdomen. You also get congestion that keeps you up at night or wakes you up at night. And sometimes people are unable to lay flat because of congestion in their chest. And they'll often have to use more pillows underneath their head to kind of keep them up so that they can breathe. So those are the most common symptoms. But as we get older into our 8th and 9th decades of life, sometimes those symptoms can be a little more atypical. It could just be exertional fatigue. Sometimes it could be even confusion or just, decreased level of functioning. So you kind of have to use your detective work sometimes. And it also is very difficult to kind of diagnose in people who aren't very active, because you don't really know if it's because of deconditioning that they aren't active or because of heart failure. So when in doubt, I think it's always worth bringing up to your doctor. It's also more difficult to just diagnose in the obese or overweight. So that's another important part of staying physically active, or as physically active as you can, because it gives you a baseline so that if you lose that, you can, okay, that's not normal. And then there's some common conduction diseases that I deal with. Atrial fibrillation is a very common one. That's an irregular heart rhythm that we see that is generated in the top left chamber or the left atrium. And many times I see it and it's completely asymptomatic. I detect it, or their person's general practitioner will detect it by just doing a routine EKG, and the person doesn't even know that they have it. And so if you're asymptomatic, it actually makes it easier. You can live a very happy, fulfilling life in AFib, but as long as your heart rate is under control, because sometimes people's heart rate gets up too high. But people can also be very symptomatic and debilitated with it. And then we talk about perhaps getting them out of atrial fibrillation by a number of ways. That's what I was talking about previously: ablations, cardioversions. There's different things we can do, medications. But the most important thing I talk about when I talk about AFib is that it increases your risk for strokes. And I'm sure you guys have seen all kinds of ads on TV for these blood thinners. But it is important, and this is an individualized decision, but many people are on blood thinners to prevent strokes if they have AFib. And then we also talk about conduction diseases. Remember, I had said in the normal aging process, you can get some scarring or cell loss from the conduction system. But sometimes that can occur to a dangerous level, and you can get what's called sick sinus syndrome. You can also get atrioventricular block or AV block. And the symptoms to really look out for are excessive fatigue, delirium or confusion, lightheadedness, or even passing out. Now, a lot of these these symptoms can overlap with other disease states. So that's why it's really important you get checked out as soon as you can, because then we can diagnose it simply with an EKG. And we're able to treat it fairly simply. Typically, the treatment involves putting in a device called a pacemaker, which takes the place of your body's normal pacemaker. And then we talk about valve disease as we get older. By and large, the one that I see the most is aortic stenosis, which is progressive scarring and calcification of that aortic valve. If you remember, that sits between the bottom left chamber and the aorta. As we get older, it gets more scarred and calcified sometimes, and sometimes to a point where it causes narrowing in the valve opening. And over time, that can lead to symptoms of heart failure, which would be like shortness of breath. Sometimes it can lead to symptoms of angina, which would be like chest pain or pressure with exertion. And sometimes it can lead to even lightheadedness or passing out. So this is also very easily diagnosed. As long as someone puts a stethoscope on your chest, we can usually hear something called a murmur, and that would prompt us to get an echocardiogram, and we can readily and reliably see this valve. So it's pretty easily diagnosed. So if you have symptoms, it's important to get checked out. So, sometimes, previously this was kind of like advanced aortic stenosis was considered almost like a death sentence. We couldn't do anything for you, because if you couldn't tolerate open valve repair, because really the only way to treat it is to replace the valve. And the only way we used to have is open valve repair or surgical valve repair. Well, now we have more options. So we've got something called TAVR, or transcatheter aortic valve replacement. If you remember, I was talking about the angiography where we go in with a catheter. Well, in this case, we go in with a catheter that actually has an aortic valve in it, and we're able to go retrograde up your aorta and expand a brand new spanking valve over the old diseased valve. And actually, the calcium from the diseased valve actually helps hold the new valve in place, which is pretty amazing. So we can do an aortic valve replacement without ever opening your chest. We actually go in through the artery. And that's a pretty cool new thing, relatively new thing. It's been around for about 10 years now. And if you end up being evaluated for this, or you have one, you're in good company, because recently Mr. Mick Jagger from the Rolling Stones got a TAVR. So that's kind of our celebrity plug. So you're in good company. So, this happens to everyone. So I was previously, one thing I want to highlight when we talk about disease in older folks is we really need to highlight that, the symptoms that you have are not going to be kind of the ones that everyone hears about: the crushing chest pain, the, chest pain going up to the neck or down the arm. A lot of times people just have shortness of breath, or fatigue, or upper back pain that occurs with exertion, or heartburn pain, or throat pain. And so I think it's really important to just be vigilant. You don't want to get over anxious, and that's a fine line, but anything that you think is abnormal, there's probably a reason you think it's abnormal, and I think it's worth getting checked out. So just, I think I would just give a plug to trust yourself and your intuition about your
Oops, Suj, you're frozen for me. Is anyone else frozen here?
I was frozen too.
Thanks, Carol. Let me see if we can find her.
Yeah, I'm frozen too. This is Marilyn.
Hi, Marilyn. Thanks. I think she'll be right back. Thanks for your patience, everyone.
Excellent information. As
Yeah.
being married to a cardiologist, I have no idea about these things. So it really brings to all the terms.
It's like a little intermission.
It's an excellent program, but I don't think I'll ever remember it all.
I'm recording it so you can watch.
No, but no.
Okay.
Oh, okay, that's great.
I'm going to watch this again for sure. I mean, this really great information.
Let's see. I'm sure she's trying to get back on.
So you have 19 people on board?
Yeah, 19 people on board. Maybe we could do a 7th inning stretch.
Lindsay, welcome to my world.
Yeah, true. So let's see. All right, I just heard on the phone. She's trying to get back on. Here she is. Okay.
Sorry, guys.
Encore.
Just make sure you're still awake, right? Sorry about that. Hold on one second. That was my internet, I think.
That's okay. We get it.
All right. Here we go. All right. I apologize there. Okay. Yes. So I think we were talking about risk factors. Smoking is another one. Pretty, everyone knows about that. Sedentary lifestyle. So now some of us have, musculoskeletal or, limitations, and that's totally understandable. You just do what you can. You do the best you can, stay as active as you can. And then I added also stress and depression, because I think depression is often an under-recognized, risk factor that keeps us from really taking interest in our health and, really looking out for our health. So that all of these things I think are good risk factors to target. So I said I was a cardiologist. Well, what the heck is that? That is an internal medicine doctor that has specialized training in diseases of the heart. I am a general cardiologist. And so I do a little bit of everything with regards to heart health. So what that means is I did 4 years of medical school, and then I did 3 years of internal medicine residency, which is additional on-the-job training. And then I did 3 years of additional fellowship. Some people do 4. And then I was able to call myself a cardiologist. And then after that, some people specialize even more. Because I remember I said that there's multiple aspects of the heart. So there's sub-specialists in cardiology. There's people that do caths. These are called interventional cardiologists. They're the ones that do the angiographies and put in stents. And they specialize in the outer plumbing that I was talking about. There's electrophysiologists or electricity doctors that are doing pacemakers and ablations and treating atrial fibrillation in detail. And so they do additional training as well. And then there's advanced heart failure and transplant specialists. And those are people that deal with people with advanced heart failure and artificial hearts. And then there's also structural heart doctors. Those are actually interventional cardiologists that do the valve disease things, the TAVRs, and now we're even doing mitral valve replacements. So it's a vast field, and it's growing every day. So, there's always options. So I think, that's important to remember. So now that I've done that part, I'm going to do a complete 180. Those are my references, and I'm going to talk about the other part of my heart, the figurative part. I'm involved with this nonprofit organization called the Borgen Project. It's a national nonprofit, started in the early 90s, and we basically advocate for extreme global poverty. And as a kind of a reward for me doing this talk, I was allowed to plug a little bit. And basically we do it through advocating through the political system. We meet with congressional members. We also mobilize regular people and educate them as to how to get involved in the political process, not just for this issue, but for any issue that's important. We also issue message and kind of highlight the successes already about how we're fighting global poverty, and we're able to, dispel any myths or misconceptions about it. And it's a win-win situation. So, helping the world's extreme global poor is helpful not only for them, but also for us, because it promotes our national security, it fights extremism, it's helpful, it's a new economic market, and it's good for the environment. So the pandemic has really taught us how interconnected we are, so I think it's really important to take care of each other. And if you want any more information, feel free to go to www.borgenproject.org, or you can email Lindsay if you're interested in donating. She has a link to my personal donation page, and you can learn about fighting global poverty. So with that, thank you very much, guys. I really appreciate it. And thank you for allowing me to plug my charity. And I'll take any questions.
Thank you so much. If you want to stop share, Dr. Holman, then maybe you could see their audience. Perfect. And then just the gallery view there. So you can either unmute yourself, or you can raise your hand, or you can use the chat feature if you have any questions or comments.
No questions?
I'll at least step forward. It's something I'm going to have to listen to probably once or twice more in order to have it sink in and stay there.
Yeah.
But it's very good. It's a nice explanation, and it gives me something else to do with life.
Yeah, and that's not just you. I think that's everyone. Even doctors sometimes. It's something that we always go back to. Go back to the basics, the fundamentals, So I think it's always important, and it's always important to keep it in mind, because I think it explains a lot.
Dr. Holman, we have a question. Is there any issue with mask wearing and heart health?
No. I'm going to say no. I think, so that's the simple answer. In other words, mask wearing, I would strongly advocate for it, because the thing that's going to be bad for heart health is getting COVID-19. So I think if mask wearing, now again, simple mask wearing or surgical mask wearing isn't going to completely eliminate your risk, but if both parties are wearing masks, it reduces the risk of the droplets being passed on by about 70%, I believe. So I think to that end, it's really important. Some of my patients do have difficulty wearing the masks for long periods of time because of their underlying heart, and mostly because of their underlying lung issues. That said, I'm actually quite surprised at how well some of my patients are able to do it. And in fact, a lot of patients who've had chemo or cancer treatments, they're kind of used to this. They've been doing it even before this was a fad. So I think it can be done, and it should be done to protect your heart health overall, So that's a great question.
Another question in the chat: what is the status in the development of leadless pacemakers?
Yeah, so we do have those. Leadless pacemakers are a thing. And actually one of my partners, Dr. Reddy, is actually doing them at Mercy Hospital and at Bay State. And they're used, it's great. It's actually FDA approved already, and we're doing them. Not everyone gets leadless. It sort of has to meet certain criteria, but yeah, we are doing them, and they are FDA approved.
And what is the connection between long distance running among seniors and heart damage?
So I think, is there a specific study or anything you're referring to, or just in general? Can we ask that?
Mr. Skypeck, are you able to unmute yourself?
Well, I can speak to the general. I think that, long distance running in general is very good cardiovascular aerobic exercise. And it's very good for training purposes, and it kind of promotes longevity of health. That said, I think we worry a lot about kind of the musculoskeletal injuries and that sort of thing as we get older. I feel like if you are a trained long distance runner all throughout your life, or at least, for a good period of time, you should continue to do that activity, assuming that you don't have underlying heart disease and have not been advised otherwise by your doctors. But I don't think it's any more dangerous than, in other words, I would be more worried about you straining or spraining something than doing damage to your heart. You really have to do a lot of long distance running. And where I really worry is about people who are not conditioned to do long distance running, just starting to run. So I think as long as you do it in a methodical way and you start training from the, with small amounts and gradually getting upwards, I think that's perfectly healthy and safe.
Mr. Skypack, did you want to follow up?
Yeah, I do distance running, and I am a patient of one of your physicians in your practice.
Mm-hmm.
And I have read a number of studies that suggest there's arguments on both sides, but I have read a number of studies that suggest that running excessive distances over a long period of time does damage to the heart. So that's the basis of the question.
Yeah. So are you thinking of, there is something called Pheidippides cardiomyopathy? Is that what you're talking about?
I'm not familiar with the term, but
yeah, so in marathon runners, they can actually get a cardiomyopathy or a weakening of their heart. Not all of them by any means, otherwise we wouldn't have all these marathon runners, but that has been described. Now, I'm not aware that specifically in older patients that's accessible, like a excessive risk. But I do know that is a possibility, but I don't think that's the norm. That said, we haven't really studied a lot of older long distance runners. And I'm happy to look at if you could send me a link, maybe send Lindsay the link to look at the specific studies and kind of go through the specifics. But overall, I think regular aerobic activity is a good thing. And perhaps long distance running in a certain, a small few may not be, overall that good. But I think overall, if you're doing it in a trained manner, in a kind of a disciplined manner, I think it's a good thing for your heart.
I will search for that link and send it.
Yeah, that would be great, because then I can just comment on the specifics.
Well, that's all set for the chat. Does anyone else have a comment or question?
Yeah, I do.
Go ahead, Jeannie.
All right. Way back in the old days, my 92-year-old father was told by his cardiologist to always take an 81 millimeter aspirin every day. Like they call it a baby aspirin.
Yeah.
But modern science, are they still doing that? In other words, so that you won't have a heart attack, you take an aspirin every day?
Yeah, we were, up until very recently. There've been some recent trials in the New England Journal that have kind of called that into question. So we used to do it for almost everybody as a primary prevention, meaning preventing the first heart attack or stroke or vascular event. But we found that in a lot of people, the number needed to treat, or the amount of people that you would need to treat to prevent one of those events, is actually exceeded by the major bleeding risk. So many people are telling their folks who've never had a heart attack or stroke that it's an individualized decision. And a lot of people are not really advocating for widespread use of the baby aspirin anymore for primary prevention. Now, that said, I still recommend it in my patients who've had a heart attack or stroke before, that's called secondary prevention, to prevent the second one from happening. I still think we see some benefit there. So yeah, I do recommend it for my folks who've had heart attacks or evidence of heart disease, and people who've had strokes before, but not necessarily for primary prevention.
One more question. Would possibly, since you're saying, I haven't had a heart attack, but possibly every other day? You know, I mean, I'm trying to.
Yeah,
No?
I don't know that that's going to do much better. That regimen has never really been studied, and I feel like my thought is, if you're going to do it or don't. You know what I mean? Because if you do it kind of half-heartedly, you're going to get some of the risks that are associated without getting the full benefit.
Right. Well, thank you very much. I've been pondering that question for a while now.
Doctor, I'm on Eliquis, and I was told not to take any of that baby aspirin.
Yep. Yeah, I would agree with that. I think that your bleeding risk would be excessive to be on both.
Okay.
That's what I'm assuming. Now, some of these questions I'm answering as a general. There may be specifics to your specific care that I don't want to, step on any of the toes of the medical providers you guys are seeing. So just kind of take it as a general, but it makes sense to me that would be the case.
All right. Thank you very much.
Well, I wanted to say a big thank you to Dr. Holman. If you enjoyed today, maybe you can do her a favor and look at, it's www.borgenproject.org, right? And
Yes, thank you so much.
That's kind of near and dear to her heart. So I'm glad she got to share that with us. And I recorded today, so I'll put this on our YouTube page if that's okay with you.
Yeah, sure.
And so people can rewatch it. Oh, Dr. Skypack said Dr. James O'Keefe published in the Mayo Clinic Proceedings. So I'll let
Okay, perfect. So if maybe you can pass along emails and I can
do that
separately. Excellent.
Well, thank you so much. Thank you all for being here.
Bye, guys.
Bye.
Thank you very much for being here.
Thank you.
Thank you so much. All right.
Thank you, Lindsay.
Thanks for being here. Good to see you.
Thank you. Thank you, Lindsay.
Thanks for being here.
Thank you, Lindsay.
Thank you. Thank you, Lindsay.
Thank you, everyone. Thanks for coming. Bye.